I'm David Glazer, and I'm here to talk about incident to billing and shared visits. I'll start off by just mentioning I have other non-physician practitioners in the title. We're not going to be focused on that as much, except to the extent that it ties in with incident to and shared visits. So if you're thinking about how do we bill for psychotherapy services, you're going to be disappointed. You are going to be angry at me, and you could then maybe have a counseling visit to go talk about your anger with me. So only other announcements. Next month, I am not sure. We may have a webinar by my colleague, Lori Hartman, on provider contracting tips. That's a possibility. The other possibility is we may take a month off. I'm not sure. I do know that on 7/11, in addition to consuming a Slurpee, we will have a really good webinar. This is for everyone who has ever conducted an internal investigation. Two of my colleagues, Belsey Foster, Lucine Hoppy, and I will be doing privilege issues when you conduct internal investigations. So if you've got anyone who, if you do that or have others who do, sign up. And then final announcement, remember all of these webinars are available on our website for free. Like this one will be up, usually by Friday, certainly by next Monday. And so if you find it useful, you can send it to a friend or watch it again, or if you have to sign off in the middle, you can watch it. All right, let's dive in. So I'm often talking about how important words are, and we'll have a couple of illustrations of this. I remember when I first heard the phrase incident to. I was a baby lawyer. My colleague, Kit Friedman, was trying to give me a project, and I didn't understand what we were talking about. And I think it took me a solid 6 weeks to understand the idea, and I've seen transcriptions sometimes where it's incident to, TOO, or with the number 2, right? And I think one of the things that makes this concept so complicated is the word choice. So the phrase is short for services that are incident to a physician's professional services. So the idea is that it's a service that's kind of ancillary to whatever a doctor is doing. It's separate and distinct, but related. But I just think the wording here helps make this complicated. And our goal today is to try to A, explain what this stuff is, and then B, get rid of a bunch of myths, because there are some humdingers out there. There are some things that almost everyone believes to be true, and they're not. So this is designed to cover work that's initiated by a physician and normally included by the physician's bill, but might be provided by someone else in the practice. So that's the basic idea, all right? Now, one of the problems, and we'll talk about this in a couple of slides, is that the term incident E2 is used differently to describe hospital services than clinic services. Same words, different meaning. And you go, wow, that makes things hard. And yes, it does, okay? As we go through the slides, keep in mind the regulatory hierarchy. So, we start at the Constitution, we go on with the statutes, which you might think of as laws, all right? Then we've got regulations, things you find in the Federal Register, or really in the Code of Federal Regulations. Then we have Federal Register Preamble is next on the list. Then we've got manuals, and then carrier guidance. That hierarchy is really important, and I struggled on how to organize today's talk. I couldn't decide whether I wanted to go through the hierarchy and start with the regulations, or the statute, then go to the regulations, and then go to manuals, or if I wanted to do it thematically and pick a topic like supervision. And I ultimately decided it's probably more important to do it by topic, but that's a struggle here. Because remember, if something is in the regulation and not in the manual can't undo something that's in the regulation. We'll talk a little later about the brand memo in more detail, but it's a memo that came out in January from then, I believe she was Deputy Assistant Attorney General Rachel Brand, she just left to go to Walmart, saying, hey, the government shouldn't use manual provisions to enforce the law. So we'll talk about that, but keep this hierarchy in mind. And then people use words really poorly here. It's endemic, and words matter. Gary Larson captures this so well. Ha ha ha, Biff, guess what? After we go to the drugstore and the post office, I'm going to the vet's to get tutored. Well, we'll talk about how, for example, the word diagnosis disappears in the incident to rule, and it shouldn't. We'll talk about what the course of treatment means and how people misuse it. So words matter. So let's start with the statute. So where you see SSA, that's the Social Security Act, Section 1861S is where the benefits of the Medicare program are laid out. And so the law says the term medical and other health services includes the following. So 1861 S1 is physician services. S2 are services and supplies, including drugs and biologicals, which are not usually self-administered by the patient. So in other words, drugs and biologicals the patient doesn't use him or herself, that are furnished as an incident to a physician's professional service, of kinds which are commonly furnished in a physician's office and are commonly either rendered without charge or included in the physician's bill. Now that's not the world's most artfully drafted sentence, but you can see a few standards, right? So it's got to be a service or a supply. So a service is a thing someone does, a supply, an item, okay? And a drug or biological, if it's something the patient doesn't do himself. If it's incident to the professional service, it's commonly included in the bill and either done for free or included in the bill. So in the statute, those are the only requirements, right? That's all we've got. So there's an interesting thing if whatever you're doing doesn't, if it fails any of the other tests we're going to talk about, you'll have an argument that going back to the statute, these are the only principles. Okay, so just keep that in the back of your mind. Now I want to go on the statute a little bit more. So first, it talks about hospital services incident to physician services that are rendered to an outpatient. And you'll see I threw an asterisk in here because this is the first thing that adds to the confusion. So when a hospital is billing for things that are happening to hospital outpatients, those are called incident to. But we don't use any of the tests that we're going to be talking about in this webinar. In fact, the tests are so different, it's really separate and apart, and the phrase incident to is just misleading here. But you need to understand when someone is talking about incident to in the hospital, they mean something else, all right? So confusing, and the only way you understand that is looking at the statute. So when we talk about stuff in the hospital, and we did a webinar on ancillaries, Katie Ilton and I did in February. No, February was overpayments. I think it must have been March. It was everything you wanted to know about ancillaries. And you can watch that. Katie does a nice job of explaining all of this stuff. So diagnostic services in the hospital can be done under arrangements, but they're done under this weird incident to thing. Then the next benefit under the law are diagnostic X-ray tests. And this is important because under the law, diagnostic tests are listed as a different benefit than incident to. Up until about 2002, what was then HCFA, now CMS, said that when you do an X-ray or a diagnostic test, you can do an incident to a doctor's service. And then I'm pretty sure it was 2002, it might have been 2001, they said, wait a minute, different benefits of the Social Security Act, you cannot do diagnostic tests incident to. Different benefits, different requirements. So if you're thinking of any diagnostic service, those can't be done incident to in the clinic setting. And the way we know this is a quote out of the Medicare manuals. Services should meet the requirements of their own benefit category. Diagnostic services are covered under 1861 S, I think of the Act, and MACs can't apply, or diagnostic tests under 1861 S3 are subject to their own coverage requirements. Depending on those tests, supervision may or may not be more stringent than the supervision requirements for other services and supplies. So this is just interesting. It's a good thing to do periodically is go back to 1861S and look at the different benefits. So I remember a client called us a little while ago and said, hey, do we need to have a doctor on site to do pneumococcal or influenza vaccines? And the answer is no, because those vaccines and Hep B are under S10 of the Act. So because they're covered under S10 of the Act, they don't get covered by the incident to rule. So this is super complicated in a way, but actually it's kind of easy if you think about the statutory benefits laid out in 1861. Then physician assistants, nurse practitioners, clinical nurse specialists, midwives, psychologists, social workers, physical therapists, and occupational therapists all have their own benefit categories, and they can provide services directly without direct supervision. Now, what's even more confusing, those folks can be done incident to. CMS takes the position that diagnostic tests have their own benefit category and therefore can't be incident to, but the people listed on this slide can be done incident to, all right? So yet more confusion. All right, so this is a good place to segue into who can do evaluation and management services. So Medicare will pay for an E&M service by certain non-physician practitioners, and look at this list because this list is exhaustive. NPs, CNSs, and midwives can do E&M services and get paid under, for a 99212, 213, 214, 215, and any of the other 992 asterisk CPT codes, all right? What's kind of weird, look at the last purple sentence. You're not supposed to pay for evaluation and management codes billed by physical therapists in independent practice or occupational therapists in independent practice. And it's interesting to me, I don't know why those two are called out here. And if you look in the lower right, I'm trying to put citations for every quote I've got in here. So this one is the Medicare Claims Processing Manual, abbreviated MCPM, Chapter 12, Section 30.6.1. So a thing to know, NPs, CNSs, and midwives can bill for an E&M service, and they can do it incident to, they can do it on their own. No other medical professional can bill for an E&M service on their own. And when I say on their own, they can't even bill incident to. If you've got a patient who comes in and they see a psychologist or they see a medical assistant, that service can't be billed with anything other than a 99211, which is a nurse visit in CPT. You can't bill a 99212 or up for those encounters. At least that's my understanding of the policy. There might be an argument one can concoct, but that's the position the CMS takes, and it's the risk management position I would take. So why would you ever want to bill incident to? The answer is a simple one. If you bill under incident to, you get to bill under the doctor's full rate. You get 100% of the physician fee schedule. If an NP, CNS, or PA does a service on their own, they get paid under the physician fee schedule, but they get paid at 85% of the amount that a physician would receive. And this is another weird semantic thing. It's still the physician fee schedule, even though a non-physician practitioner is getting the payment, but they get 85% of the amount. And people often say to me, David, there are a bunch of headaches here. Why would we ever bill incident to? And my answer to that is, do you try to buy things on sale? And I do, I'm cheap. If you can get something at a 15% discount, or in this case, a 15% bonus, you'd always do that. And so there's an economic incentive to bill things incident to if you can. In addition, Stark has an in-office ancillary exception. And if you're using the in-office ancillary exception, doctors can get credit for services that are designated health services that are performed incident to their work. So if you've got a DHS like physical therapy or chemotherapy and you want to credit doctors for that work, you can do it if the work is done incident to, and you can't if it's not. So why would you avoid incident to? Well, first, we're going to talk for an hour about the complexity of it, and so I guess you avoid that. In particular, there are some supervision requirements you have to pay attention to. If a new patient comes in and they don't see a physician, you can't bill that incident to. And then there's this weird billing thing. We'll talk in a bit about how you have to bill incident to services under the name of the doctor who performs the supervision. So if Robert is the patient's regular doctor and he's out of the office when the patient comes in and I see the patient, we're going to bill that patient under my name. But the bill's going to go in my name, and the patient doesn't know who the heck I am. And so they're like, why did Robert not charge me? And they call and they accuse you of fraud. So those are the negatives of incident to billing. And then, like for some services like physical therapy, there's no upside to billing incident to. The doctor doesn't get paid more than the physical therapist would get. So here are two slides that I use to describe incident to billing if I wasn't taking an hour to dive into it. And feel free to steal these. We're going to go through them very quickly because we're going to go through them in much more detail as what I'm going to do here is dig through the regulation and the manuals in some detail. So basically, a clinic can bill incident to for services if the clinic pays the expenses of the ancillary person. They provide the medical direction. The first visit for a particular course of treatment is with a physician, even if later visits are only with non-physician practitioners. And we're going to talk at length about this. People often say you can't bill incident to for a new problem. That is wrong. More later. The service has to be something typically done in an office. It can't be something that's in a hospital or a nursing home where you can use the shared visit benefit, but that's different. We'll talk about that. A doctor has to be in the office suite, and the service has to be billed under the supervising physician. So this is incident to in a nutshell, all right? But let's get out of the nutshell and dig in more aggressively. And so what we're going to do, this is going to be almost a Talmudic study. We're going to look at the regulations and the manuals and see what they say so that you really understand why the rules and policy are what they are. So the regulation in question is 42 CFR 410.26. And it starts off in A with definitions. So these are the defined terms that are used in other places. So one of the biggies, the term the regulation uses is auxiliary personnel. That's kind of everyone other than the doctor. So it's in any individual, note any individual. So we're going to talk in a minute about the question, can a physician be incident to another physician? Well, to answer that question, ask yourself, is a physician any individual? The answer is yes. So doctors can bill incident to, but we'll come back to that one. So any individual who's acting under the supervision of a physician, regardless of whether they're an employee, a leased employee, or an independent contractor, so the employment relationship doesn't matter, and whether they're of the physician or of the same entity that employs or contracts with the physician. So the physician also can be an employee, leased employee, or an independent contractor. They haven't been excluded from the Medicare, Medicaid, and all other federally funded healthcare programs. So you can't use incident to as a way of getting around a person who's been thrown out or who's had their Medicare enrollment revoked. And they have to meet any applicable requirements to provide incident to services, including licensure, imposed by the state in which the services are being furnished. So one of the things that means here is that your answer in Texas might be different than your answer in Louisiana, because state licensure rules are going to matter. And if whatever you're talking about requires a license, the person has to have the license. So now, I was down in Florida a couple weeks ago and I saw this sign, no soliciting postings of handbills or flyers. And I thought to myself, whoever would solicit someone to post handbills or flyers? Because we have some missing commas. And the language here matters a lot, all right? This is the any individual is really a big, that word matters. So they're acting as the supervisor regardless of whether they're an employee. We've already covered that one, so we're just moving on. I just mangled that. So can one physician be incident to another? And I hear a lot that the answer to this is no. The conventional wisdom is not something to rely on, all right? I think this is really clear. Physicians are any individual, and if they're any individual, we're good to go. How do I know this? Well, here was a comment that appeared in the Federal Register. So many commenters wanted us to restrict the definition of auxiliary personnel so that only certain individuals could perform a given task. They wanted us to mandate only audiologists could do cochlear implant rehab services. They wanted us to permit only PTs or OTs to do PT and OT incident too. They kind of go on and on. We have not further clarified who can serve as auxiliary personnel for a particular incident to service because the scope of practice for auxiliary personnel is determined by state law. We deliberately use the term any individual so that the physician or other practitioner under his or her direction or license can use the services of anyone, ranging from another physician to a medical assistant. This seems really clear. It's out of the Federal Register from November 2001, and this should definitively put to bed the question of can a doctor bill incident to another doctor. But like many things, I need to put a little asterisk here, right? What if we've got a doctor who's lost his or her license? Can you do it then? No, because remember, the person needs to have the license to do whatever service we're talking about. So if they're missing the license to do what they're doing, they're outside the scope of practice, now it's a non-starter, right? Well, what about if you've got a Medicare doctor who they're new, they're started up, and they haven't yet been enrolled? Can you use this as a way around that? There, I think the answer is probably yes, but with another asterisk. The service is going to have to meet the incident to requirements. So you can't use that person to see new patients, right? Because the incidental thing means we need an initial service by the physician to which the subsequent visits are an initial part, or an incidental part. We'll come to the text of that in a moment. So there's going to be limits as to who you can see. But in other respects, conceptually, can a doctor bill incident to another? Yes. So now let's look at the Medicare Benefits Policy Manual. That's where this is coming from. So the physician who's furnishing the services or supplies or supervising the auxiliary personnel must have a relationship with the legal entity that's billing and receiving payment. And that has to be an expense that's incurred by the physician or the legal entity who bills. So basically, here's where this would come up most commonly in our experience. You're a physician clinic. The hospital says, hey, when you do rounds, we're happy to give you this nurse practitioner. You take her on your rounds or take him on your rounds with you. If you're getting that person for free, it's not an expense you're incurring, and you can't bill for that person's work incident to. Now, if it's in the hospital, we're going to have another issue that we'll come to. So so there's double stars there. But if they send you to the clinic, the nurse practitioner is coming into the clinic to work with you, not an expense, can't use it. But if you pay the hospital for the expense of that person, solves the problem. All right, back to the regulation. So direct supervision means that the level of supervision provided by the physician has to meet the level as defined in the diagnostic test rule. And we'll come to that one in just a second here. So what is direct supervision? This is the diagnostic test rule. Direct supervision in the office setting means the physician must be present in the office suite and immediately available to furnish assistance and direction throughout the performance of a procedure. It does not mean that the physician must be present in the room when the procedure is performed. Now, if you think about the definitions you've learned in your life, how many definitions include what something is not and focus more on what it is not than what it is? So this focuses on it's not in the room, but we don't know much else, right? It's just in the office suite. It offers no insight into what the office suite is. So this has been a conundrum since I started practicing back in 1992. So in 1992, we used to say we'd use the 30-second test. Can you get there in about 30 seconds? That wasn't really based on anything. It was kind of made up, but it was based on, I shouldn't say it wasn't based on anything. It was based on the idea that there's probably a principle behind this policy. And the principle is if a patient falls over dying, the doctor should be able to get there to revive them, all right? And so if you can get there in 30 seconds, it seems like that's a reasonable start for a code. That was kind of our thinking. Well, the Federal Register in 1998, there was a proposed rule that came out, and the proposed rule was never adopted. But here is the language that came along with that proposed rule. So we're not proposing that there must be any particular configuration of rooms for an office to qualify as a suite. Direct supervision means that the physician must be in the suite and immediately available. Thus, a group of contiguous rooms should, in most cases, satisfy this requirement. We've been asked whether it would be possible for a physician to directly supervise a service furnished on a different floor. We think the answer would depend upon individual circumstances that demonstrate that the physician is close at hand. The question of physician proximity for a physician referral purposes, as well as for incident 2 purposes, is a decision that only the local carrier could make based on the layout of each group of offices. For example, a carrier might decide that in certain circumstances, it's appropriate for one room of an office suite to be located on a different floor, such as when a physician's practice is on 2 floors of a townhouse. So wow, okay, there's so much going on here. First, this is preamble, so not a rule, to something that didn't get adopted as a rule. How binding is this? Not very binding. But let's just say it was binding. What's it even tell you? In certain circumstances, something's inappropriate and we don't know what it is. Holy stews of made up kind of drivel, right? I mean, try to operationalize this. And so 2 people at the contractor might treat you differently than me. They look at, we have exactly the same layout and they decide yours is okay and mine isn't. In administrative law, there's a principle that if something is arbitrary and capricious, it's not enforceable. This screams arbitrary, right? Let's operationalize it. So one of the, I think maybe the second overpayment case I ever worked on, this was like 1993 or 1994, involved a physician who was doing physical therapy. He was an orthopedic surgeon. He was on the 5th floor of a building. His PTs were in the basement. And the contractor had sought all of the money back for his physical therapy services because he wasn't in the office suite. And we went to an administrative law judge and we won. We convinced the ALJ that that was in the office suite due to the utter lack of a definition. Now, would I recommend to you that you have 5 floors separating the doctor and whom he or she is supervising? And I would say the answer to that is heck no. If you got attacked for not having sufficient supervision in that situation, would I tell you to appeal? Darn straight, all right? So I don't still know what the test is. I think 30 seconds feels pretty good. It seems like entirely arbitrary. If those 30 seconds are going up a flight of stairs versus down a hall, that's not analytically distinguishable, right? And so I like the 30-second test more than I do any kind of number of floors or anything like that. But you got to understand, I'm making up my 30-second test. I am not basing it on something that I can point to other than it's not in the room and it has to be in the suite. Okay. You know, Bjorg, there's something about holding a good solid mace in your hand. You're just looking for an excuse to smash something. And I mention this because this language is so loosey-goosey, it makes it easy for someone who wants to give you a hard time the opportunity to smash you in the face with a mace. All right, so let's continue talking about direct supervision. This is what's in the Medicare Benefit Policy Manual. So similar language here, direct supervision doesn't mean that the physician must be present in the same room with his or her aide. However, the physician must be present in the office suite and immediately available to provide assistance and direction throughout the time the aide is performing services. So immediately available, and this is where I think that 30-second test, it's direction and aid. Now, what's a little weird here, what about the phone, right? Because you could provide direction and aid through the phone. That isn't good enough, as we'll see. So first, if auxiliary personnel are outside of the office setting, in a patient's home or an institution other than a hospital or a SNF, they're covered only if there's direct supervision by the physician. They have to be accompanied, all right? So that's kind of the test. Services by auxiliary personnel in an institution present a special problem in determining whether the direct supervision exists. This is one of my favorites. I once won an appeal because of this language, and actually what appeared in the okay, this is maybe in the TMI department. I was in the shower and I suddenly remembered this language. And the particular case involved incident 2 services in the hospital. And as we're going to talk about, the government's position is that you're not supposed to have incident 2 in the hospital. And I get where they're coming from. But if that's true, this sentence is utterly meaningless. Why are we talking about the difficulty of auxiliary personnel in an institution if, in fact, in an institution there's no incident 2? And I think the problem is whoever wrote this didn't know about the other stuff, and it makes things really confusing. And we use this language Some of you have heard me tell this story before. This was a situation where my client voluntarily refunded $300,000 for incident 2 services in the hospital. Then the contractor came in and tried to seek an additional $800,000 from them after they voluntarily refunded the money. And we appealed and actually wound up getting back even the money they voluntarily refunded, and it was based on this language. This is screwed up because that language completely contradicts text out of the regulation that we're going to come to in a moment that says services and supplies must be furnished in a non-institutional setting to non-institutional patients. So this is a case where CMS has someone writing the manuals who doesn't know the regulations, and it's made things really screwy. All right. So this is just a little bit of additional language that I think we can mostly gloss over. I tried to put a lot of stuff in here. So let's go back to the regulation. So an independent contractor is a person who performs part-time or full-time work for the individual and receives a 1099. Pretty straightforward. A leased employee is an employment relationship that's recognized either by the state and it's established by 2 employers by contract so that one employer hires the services of another. So this is clinic or hospital or 2 clinics. One is saying, you can have this employee, we'll contract with you. All right, so that's a leased employee. Nothing super formulaic here. Note that a contract doesn't even have to be in writing, right? You might, for stark reasons, need a written agreement if you've got a relationship between a physician and a hospital, but you could technically, I'd recommend having writing in any situation, but you can have a lease that is oral in this context, one would think. Not recommending it, just it's a possibility. Okay, here's the non-institutional language. Well, actually, this is just the definition of non-institutional, practitioner, and services and supplies. So this is probably one of the least important slides in here. All right, so here is the actual Incident 2 rules themselves, all right? So Medicare pays for stuff Incident 2 if 1, it has to be furnished in a non-institutional setting to non-institutional patients. So this would say no Incident 2 in the hospital, but I'll put that asterisk here. If you ever get in trouble on this, I'm going to use that manual language to argue there isn't an overpayment. For risk management purposes, assume you don't have Incident 2. If you get into an overpayment situation, or you're worried and thinking you might have to refund the money, you've got a hook to hang your hat on. The services and supplies have to be an integral, though incidental, part of the service of a physician or other practitioner. So note, you can be Incident 2 in NP or PA or CNS. I'm going to pause for emphasis here. In the course of diagnosis or treatment of an injury or illness. Let's just say that again. In the course of diagnosis or treatment of an illness or injury. Now, let's go look at the manuals. So this is the Medicare Benefit Policy Manual. So where a physician supervises auxiliary personnel to assist him or her in rendering services, if there's a physician's service rendered to which the service of such personnel are an incidental part, and there is direct supervision by the physician. Okay, I'm good with that. This does not mean, however, that to be considered Incident 2, each occasion of service by the auxiliary personnel need always be the occasion of the actual rendition of a personal professional service by the physician. Okay, so far we know the doctor doesn't have to be there all the time. Such a service or supply could be considered Incident 2 when furnished during a course of treatment where the physician performs an initial service and subsequent services of a frequency which reflect his or her active participation in and management of the course of treatment. A few observations. First, where's the word diagnosis? It just disappeared from this. We're only talking about a course of treatment. Okay, that's a problem. The regulation, which is higher on our pecking order, says you can do diagnosis Incident 2, and we've just thrown that away. First thing to note. Second, this is the language that people rely on to say that if a patient has a new problem, you can't bill Incident 2. All right? So let's look at this. Find the where on this slide the word new problem appears. It does not. it talks about a course of treatment, okay? Now, I would say it should say a course of diagnosis or treatment if it wants to follow the reg. Someone who wrote this screwed up. But let's think about what a course of treatment is. If you've got a patient who's on chemotherapy and they develop an infection, do you think that that infection is part of the course of treatment? And I don't think that reasonable people could differ on this. I would say absolutely. Now, is that infection a new problem? Yes, they didn't have the infection yesterday. It's a new problem. It's also part of the course of treatment. So when people say you can't do incident 2 for a new problem, they're wrong, all right? They're incorrectly interpreting this manual provision that doesn't talk about new problems. It talks about course of treatment. Now, here's another question. Child has a series of ear infections. They keep coming in. Now they get strep throat. Is that the course of treatment? And here's a more interesting question. Is it the course of diagnosis or treatment? Sure feels like it to me. You know, the fact that diagnosis is in there means it can be something new because you don't diagnose old things, you diagnose new things. So I think we've got a broader term here than most people think of when they think of incident 2. The words new problem don't appear in the regs or in the manual. So I think I've just said something that I'll bet contradicts what you've heard from the overwhelming majority of people. And I know we've got a bunch of questions already. I should have grabbed one of my colleagues to read questions for me. So we'll do them at the end, and I will try to slog through them. But if you've got questions about this, ask them. But I know this is kind of different than everything you've heard before. I'm really confident in it based on what's here. This does not feel like an aggressive read to me at all. This is just a plain reading of the regulations and of the manuals. And something has taken on a life of its own because people skipped reading the text. All right, back to our regulation. So the services and supplies have to be commonly furnished without charge or included in the bill of a physician. Not a big deal here. The services and supplies have to be commonly furnished in the office or the clinic, so you can't bill brain surgery incident 2. In general, they have to be provided under the direct supervision of a physician, blah, blah, blah. They don't. Now, let's skip to the purple. The physician or other practitioner supervising the auxiliary personnel need not be the same physician or other practitioner who's treating the patient more broadly. Now, let's go to the red. However, only the supervising physician or other practitioner may bill Medicare for the incident 2 services. So, whose name is supposed to be on the claim? The supervising professional. That's a change from back in 2002. Medicare used to let you do it under either one, and now they're saying in the regulations they want the supervising doc on the claim, okay? Now, this gets screwed up a lot. In fact, I got a call yesterday from a client, actually a potential client, I guess a new client, who had this problem. And they're like, we're screwed, right? Or we could go SOL for, I don't know how much I can swear on here. I've become law school was bad for my mouth. Good news for you. You are not SOL just because you've billed under the wrong person. I couldn't believe this call yesterday. This new client paid some law firm tens of thousands of dollars to have the law firm tell them they needed to refund hundreds of thousands of dollars because they had billed under the wrong person. And the Medicare Claims Processing Manual, and I just blew my credibility because I failed to capitalize the P in there, I don't know what I was doing, says that an otherwise correct Medicare payment made to an ineligible recipient under a reassignment doesn't constitute a program overpayment. Basic language, it's been in the manuals. It used to be in the Medicare Carriers Manual in section 3060, I think 3060.E back in the day. It's been around as long as I've been a lawyer. This has always been true. So someone paid tens of thousands of dollars to a lawyer for a thing, like when they called me, it's literally a 5-minute phone call. It's as long as it took me to read this slide to answer this question. They did not need to refund the money. And if you billed under the ordering physician, not the supervising physician, epoxy on both your houses. You shouldn't have done it that way, but you don't need to refund the money, all right? And that's really clear. Big deal. And I don't know why people get this wrong so much, but they do. All right, back to our friend, the regulation. So the services and supplies have to be furnished by a doctor, practitioner with an incident to benefit, or the auxiliary personnel. You have to follow state law. It's got to be an employee or an independent contractor, and claims for drugs are payable only incident to blah, blah, blah. Okay. There are limits, and we're not going to focus on this. Basically, you got to meet the PT and drug rules. Okay, fine. So that's incident 2. All right. I think we've covered that. I've got a bunch of questions, but first we're going to do shared visits, and we should have time for questions. I think we'll get done pretty close to on time. So shared visits. It's fairly difficult for me to say, but not as difficult to explain. So shared visits. So let's look at the statute for shared visits. Oh, wait, there isn't one. Let's look at the regulations for shared visits. Same thing. They don't appear. The shared visits are a new creature. I should have looked up when shared visits came into existence. If I'm guessing, I'm going to say it was somewhere around 2011-ish. It's fairly recent. I mean, I'm old, right? So I've been doing this since 1992. I think of 2011 as recent. But it's a new concept. There's sub-regulatory guidance, which we're going to pour through, which says any face-to-face portion of an E&M encounter. So the first question is shared visits a thing? And I don't really know, because the Brand memo leaves shared visits in this gray state. So I mentioned the Brad memo at the beginning. You can see this is a January 25th memo that says the government should not use guidance, so things in the manuals, anything that isn't a regulation that came out through the APA and properly promulgated, as a mechanism to affirmatively enforce the law. And so this only exists in sub-regulatory guidance. And so this memo, if the government follows it, would mean that the government can't use anything in the shared visits language that we're going to talk about to try to recoup an overpayment from you. Now, a couple of things to note. This memo only applies to the Department of Justice, and contractors aren't part of the Department of Justice. And that correctly causes some people to say, well, this memo isn't binding on contractors. And that's true. But note a couple of things. First, this memo is, I don't think, creating new law. This is stating what I believe the law has always been. And second, in the Medicare appeals process, you start off, dealing with the contractor. You go to an administrative law judge, then the departmental appeals, then the Medicare Advisory Council, and then you wind up in district court. And once you get into district court, the U.S. attorney is representing the government, and they would be bound by this memo, I think. So I would argue it still applies in the overpayment context. But like I said, this memo isn't law. Then the law is, if it's not a regulation, it has to be interpreting a regulation in order for the government to be entitled to deference. So a lot of way of saying, I think that this shared visit stuff is really fuzzy. But let's look at what it says. So first, we're looking at Medicare Claims Processing Manual, Chapter 12, 30.6.1. In the office or clinic setting, if the physician does an E&M, then you have to report it using the physician's UPIN number. If the E&M is split or shared with a physician and a non-physician practitioner, NPCN, MPPA, clinical nurse specialist, or clinical nurse midwife, the service is considered to have been performed incident 2 if you meet those requirements, and the patient is an established patient. If the incident 2 requirements are not met for this shared split E&M service, the service has to be billed under the NPP's UPIN, and payment will be made at the appropriate physician fee schedule payment. So where does the established patient thing come from? It comes from the idea that you need to have an initial service by the physician that this thing is an incidental part of. Now that said, I think it's pretty clear that if a new patient comes in, on the day that they're there for the first time, you can have a quote split shared visit, like the doctor and the NP can see the person on that first day, and you can bill. You can combine their work into one bill and bill for it. And whether you're calling that a split shared visit or incident 2 is semantics. The outcome, I think, is crystal clear. So when a hospital inpatient or outpatient or emergency room E&M service is shared between a physician and a non-physician practitioner from the same group practice, and the physician, so let's just stop at the same group practice. If you're borrowing an NPP, remember, from the hospital and not paying for them, this doesn't work. So you got to at least be leasing that person. Okay, but let's go back. The physician provides any face-to-face portion of the E&M encounter with the patient. The service can be billed under either the doctor or the extender's UPIN. However, if there was no face-to-face encounter between the patient and the physician, e.g., even if the physician participated only by reviewing the patient's medical record, the service may only be billed under the non-physician practitioner. So here, the test is face-to-face encounter. Okay? Pretty clear, I think. So I give then a couple of examples. The NPP sees a hospital inpatient in the morning. The physician sees them later with a face-to-face visit on the same day. This seems crystal clear. Combine those two into one service. You can bill under either the doctor or the non-physician practitioner as you choose. I would say you would always choose the doctor because you're going to get paid more, right? So that seems easy. In the office, a non-physician practitioner performs a part of an E&M service. The doctor completes it. If the incident 2 requirements are met, the doctor reports the service. If they're not met, you have to use the NPP according to this example. I actually kind of disagree with this example. Well, that's an interesting question. I don't know how the incident 2 couldn't be met, I guess is really what I'd say. I guess the only way I could see them as not being met would be either the NPP wasn't an employee of the doctor, or the doctor in the middle of the visit left and no other doctor was around to supervise. So barring those two weird things happening, incident 2 is going to be met. All right? So this all seemed pretty simple until I had the Florida Project. So now the Florida Project is a movie, and ironically, I started watching it last night. My wife and I are about 30 minutes into the Florida Project, so don't tell me how it ends. So this was a client from Florida that called up. And I'm just going to pause for a moment to say, we occasionally run into people from other states who say, I had someone from Hawaii recently who's like, gosh, I wish we could use you as our lawyer. And my answer to that would be, I'd love for you to use us as the lawyer, and you can. We do stuff in all kinds of states. Most of what we're dealing with is federal law. If you've got a question about this incident 2 stuff, we would love to work with you. And the fact that we are not in your state shouldn't be a problem. So just if that's something that causes you angst, let it not. So this Florida client called up and said, we've heard from the MAC that a doctor has to perform a substantive portion of the visit, which is defined, according to the MAC, as one of the CPT's key components like the history, exam, or medical decision-making. Now, as we've talked about, the manual says it's any face-to-face portion of the encounter. So what gives? So first observation, a face-to-face portion of the encounter. So if you did medical decision-making only, you could do medical decision-making without a face-to-face portion, right? So the MAC is saying that you need to have either history, exam, or medical decision-making, and the manual says it has to be face-to-face. So if you have medical decision-making, you'd meet the MAC's test, but you wouldn't meet the manual's test. Interesting. Well, so let's look a little at, so First Coast is the contractor down in Florida. And it's kind of hard to read this. I apologize. I was struggling to get the language right from their website onto a slide. But if you look at the highlighted language here, this is where they say that you have to perform a substantive portion of the E&M visit involves all or some portion of the history, exam, or medical decision-making components of the E&M service. So the client also found this language from a CMS bulletin. This is actually a CMS, well, we'll get the site in a moment. So it says that a shared visit requires you to perform, once again, this phrase, a substantive portion, right? So where is this coming from? I thought it's not in the manuals. This is a medical learning network brochure, and they said two different things. They perform a substantive portion, and then they say they have to perform a portion of the E&M visit. Different wording. So I was flummoxed. until I found out that there's some language in the Medicare Claims Processing Manual in a section entitled Nursing Facility Services. Now, I don't ever read the section Nursing Facility Services, so I had never seen this. And it says in the Nursing Facility Services section that a split shared visit can't be reported in a SNF setting. Okay, so first, we can't do it. And then it goes on to talk about how if you could do it, it would be billed. This just makes your head explode, right? Can't do split visits in a shared, but here's how we're going to define split and shared visits. A substantive portion of an E&M visit involves all or some portion of the history, exam, or medical decision-making components of the E&M. So just to be clear, they're taking language in a thing that says there's no such thing as shared visits here. That's where they're defining this language, not many pages before where we're actually talking about shared visits. Whoever at CMS wrote this owes us all a giant apology. And I'm sorry, this is baloney, right? You can't publish something this way and expect anyone to follow it. And it's inconsistent with the stuff that's earlier, because the earlier language was any face-to-face portion of the visit. So in my mind, if the doctor goes in and says, hello, I think you're okay, all right? You've got a portion of the face-to-face visit. So what are some of the lessons from the Florida project? First, don't assume you know what you're talking about. I did not know that Medicare, which manual was that from? The Medicare Claims Processing Manual language existed. Found it later, right? And that's one of the big lessons for us. This stuff is complicated. Don't get cocky and think you know the answers. But as part of that, if someone tells you you're wrong, make them show you the rule. The Medicare rules are too complicated. The people who write Medicare stuff don't get it. And like I said, they owe us an apology for this one, because this is just poorly done. And when something is this poorly done, you don't need to refund money off of it, right? If someone can't write a policy clearly, you've got an excuse for not following it. And if you've done work, please don't give money back to the government because of their inability to articulate a rule. If they've articulated a rule and you don't follow it, that's different, right? If you're billing for a service you didn't do, that's different. Make them show you the rules, the second bullet on here. Someone can, so a couple of stars there. Manuals aren't the rule, right? So someone can show you a manual, that doesn't make it binding. And really just because someone shows you something in writing, they may show you that MAC newsletter, that isn't necessarily a rule. You have to have brand awareness, and what I mean by that is the brand memo. We've got a boatload of questions. I, unfortunately, am going to struggle to prioritize them because I probably should have grabbed a colleague for this. So we'll see how we do. Firing away on questions. So, did you address supervision expectations in the provider-based billing setting? Not in too much detail because they're different, and it's completely different than Incident 2. But does it follow the 30-second rule? That's kind of a reasonable way to get at it in the hospital setting. It's really different from what we're talking about in this clinic context, all right? Can a hospital outpatient department bill Incident 2 to a physician that's not part of their hospital under the Incident 2 rules for outpatient payment? So you've got a physician from the hospital B writes a referral order to have the services, and these are intensive behavioral, this is getting complicated, intensive behavioral therapy performed by hospital staff at the hospital. Direct supervision would still be available. So this one's complicated enough and unique enough. I think I'm not going to get too far into that, but just I'm going to reemphasize that when you're in the hospital, you're not in Incident 2. If it's a diagnostic test we're talking about, it's a much looser level of supervision and you should be good to go. And if you're talking about a physician service, really the only way to work there is a shared encounter. What if our MAC has documents on their website saying that Incident 2 can't be billed for new problems? Don't we have to follow that rule since they're specifically telling us this? This is a great question. So first, I'm going to go all semantic. It's not a rule. It's guidance. And this is a place where semantics really matter. You might choose to do what the MAC says because you don't want to have the fight. And that is a reasonable thing for a reasonable person to do. But the MAC doesn't have the authority to do this. And so the first thing I do is I'd get in touch with the MAC and say, you don't have the authority to do this, right? They're wrong. We should be going to the regional office and saying, you're wrong on this. So that's a reasonable thing to do, is to take them on up front, right? Be transparent on it. But and you may choose to not to follow it, but if you, I guess what I'm saying, you may choose not to have this fight and just do it. But no, you're not required to do everything the MAC puts on their thing. You just have to know that you might have a fight on your hands, and you got to be willing to engage in that fight. But the MAC does not have the ability to throw stuff on that's inconsistent with the manuals, and I think that's inconsistent with the manuals for the reasons we went into. So can a physician own and operate a freestanding PT clinic and bill incident to? So the short answer is yes, but I don't know why you'd want to. I would recommend billing under the PT's number, because then the PTs can see new patients and stuff like that without worrying about it, and the reimbursement is the same. So can you? Yes. I don't think there's a lot of benefit to it. Can an NP or PA be the supervising practitioner to a nurse for an infusion setting? In other words, can we bill under the NP or PA for the infusion services done by the nurse? Absolutely. NPs, PAs, clinical nurse specialists, and midwives are basically physicians for this purpose. You bill incident to, and then they get paid at 15% less of they get paid at 85% of the physician fee schedule. Can incident to be used when the non-physician practitioner is a hospital employee in the clinic and the physician is contracted to perform services for the hospital, so the NPP is not an employee of the physician? Only if the physician is paying, if they're leasing that person. So they've got to be incurring an expense for them. So you'd need a lease. It's not who issues the W-2, it's is the doctor paying for them. You know, flip question is employment requirements for shared services. The shared services stuff doesn't spell it out in quite the same way, but I wouldn't want to bill. I'd worry even about kickback issues if the doctor isn't incurring an expense for the person. So let's see what else we've got here. Do you know if United Healthcare, Aetna, or Cigna follow Medicare's Incident to policy? Oh, this is a great one also with commercial or Medicare Advantage patients. So here's the big problem. You got each Medicare Advantage plan does its own thing. They do not need to follow Medicare's rules. And the short answer is no, I don't. They would contractually have the ability to kind of do whatever they want, but it can't be more restrictive than Medicare. So whatever they're doing has to be at least as generous as what Medicare is doing. If it's at least as generous, it's fine. So they could follow Medicare's rules exactly. They can't follow them more stringently. And that's kind of all I know on that. We have new providers who bill for work in the clinic for us. Let's see, we're provider-based billing, so under the hospital for the billing. And we don't have approval for Medicare yet. Can we bill under another doctor in the same clinic? There's a lot going on here. So if it's a provider-based billing, that's outpatient hospital department. So remember, Incident 2 doesn't apply there. We're now in shared visit land. And so you're now in shared visit land. It's an interesting question as to whether you can do a shared visit for a physician or not. I haven't given that one a lot of thought. I'm ducking this one, I think. Does 42 CFR 410.26 apply to outpatient prospective payment, Incident 2 rules, or just the physician Incident 2 rules? That's just the physician Incident 2 rules. The hospital stuff is entirely different. All right, I think we've gotten through, wow, this is like almost perfect. Robert, it's like exactly the top of the hour. I think we covered the questions. There's kind of, certainly happy to look at them. The fact of the matter is, we love answering Incident 2 questions that just are not as free as they are on this webinar all the time. So remember, in June, we may have Lori Hartman talking about provider contracting. On 7-11, get your Slurpee and listen to how to use privilege in internal investigations. And if you thought this was useful, if you think that there are people in your organization who would like it, you can send them the link and they can suffer through my bad jokes and puns and my rants. Thanks much. If we can help you with anything, call any of my colleagues anytime. Enjoy this lovely May day. Thanks.